Okay, so welcome to the fourth edition of Tuberculosis. Yes, it is going a bit long because it is a big topic, but today's class will be short one. Why? Because we will be specifically talking about only one aspect of tuberculosis in today's class, that is something we call the end TB strategy. Now, tuberculosis we know is very much communicable, transmittable from one person to another, very prevalent throughout the world. Now the scenario is changing, and with the changing scenario you need changed policies, changed goals, changed targets. I cannot stick back to what I have thought 20 years or 30 years back before this program started. I cannot clinch on to that. I have to constantly modify myself, improve myself. So that's today's topic, the end TB strategy. Now, TB cannot be stopped by me alone or you alone or any state alone or any country alone or any continent alone, because TB happens to specific people, and these people always travels from one place to the other, one district to the other, one state to the other, one country to the other, one continent to the other. So you cannot keep it confined into a certain area. A person who is having TB may or may not show symptoms, so you may allow them to move. Okay, you can go wherever you want to, but he or she might be actually spreading the disease without our knowledge, without any kind of suspicion to anyone. So that will create a huge problem. So that's why WHO says that we have to unite together to stop TB. The whole world has to take action together in order to stop TB. Now, these are certain posters that we have from World TB Day. See, these are four class of people, four sections of people which we have shown in this particular slide. One is a head of state, let's say, what we call a health minister. Head of state means the CM of this particular state. Then you have the Minister of Health. Then you have the doctors. Then you have the civil society advocate. You need all these people to come together, take leadership approaches, and work for the betterment of TB patients and work for the stoppage of spreading the disease of tuberculosis. Again, over here, if you can see, the one who looks like a professor is a pharmacist. Then you have the health workers, nurses, and childhood TB survivor. You remember a person named Malala Yousafzai? I think she got a Nobel, if I'm not wrong. She was from Pakistan, who was shot in the head, and she became an advocate of women's right and women's education in the underprivileged areas or in the developing countries or underdeveloped countries. These are young leaders. They are the survivors. They lead as an example to motivate others. Similarly, we need small kids who had survived the childhood tuberculosis. We need them to come up. We need to focus on them. We need to present them to the society to see if they can come out from this particular disease. Why can't you? We have to portray them to the society so that the society gets motivation from their story and actually comes up to take the particular treatment. The stigma should be curtailed or should be removed as much as possible. Again, the health workers need to be helped. The ashas, the social health workers, the pharmacists, everybody needs to come together, work in joint hands in order to stop the spread of this particular disease. Now, why am I saying that the head of the state, the Minister of Health, a doctor, a civil society advocate, a pharmacist, a nurse, a health worker, and a childhood TB survivor has to come together? Why? Because TB is not one specific person's problem. TB is the problem of the society, and these are 8 genuine class of people who works with TB all the time. Survivors, yes, survivors will have to deal with it. They have dealt it during the treatment phase and they have to deal with it once they come out, because people do have a stigma कि इसको तो TB था, so they have those negative notions. So they have to deal with it throughout not throughout their life, for the next few years of life after they come out successfully from the treatment. So in order to stop all these stigmas, the government, not only the government of India, the WHO has advised a lot of programs. Now, before I talk about the program of this particular Stop NTB program, I would say that we have a program called RNTCP. This program will be taught to you in great details once you come back, not on the online sections, because it is a very complicated scenario and we want the best faculties in our department, the people, the stalwart who have actually worked with it to teach you. So in today's class, I'll be very brief about this NTB program. See, in 1994, if you can see in the slide over here, the 1994, the DOT strategy was first formulated. But before I go to this 1994, we have to understand one thing, that why are we talking about all these programs? If you go by the calculation, the data that we have, a majority of the population is actually suffering from tuberculosis, whether it is symptomatic or asymptomatic. Let's say if 9 million people are suffering from tuberculosis at a specific point of time, 3 million are the cases who have either not been diagnosed, who are either not taking treatment, who are not at all, cooperating with you with the search of the case or treatment of the case or to follow-ups and everything. So these 3 million is again will cause a problem for the society. In order to make sure that we overcome this hurdle, all these strategies were made. Now in 1994, think about how many years? 25 years from now. 25 years back from now, if I think about it, and on those days when the tuberculosis treatment just got started, the better treatment ones, the idea was to halt. The disease was progressing at a huge speed of light, let's say. We had to halt it. Now, how are you going to halt it? You have to bring a lot of mechanism, you have to bring a lot of stakeholders into the loop. You have to make a lot of countries take action. You have to make a lot of bodies take cognizance of the situation and work for betterment of that particular problem. So in 1994, the World WHO, the World Health Organization, had advised a program called the DOTS strategy. Directly observed treatment, short course chemotherapy, which we had talked about in our last class. Now, in this particular program, what the WHO said कि भाई we need 4 things. 4 things. What are those? First and foremost, the government has to be committed to this program. If the government is not committed, the fundings will not come. So obviously, if the funding is not there, the treatment to the poor people, the needy people won't be there. So obviously, it will be a failure of the program. So the government has to commit. Once the government commits, you get the funds, you get the push from the government. It will help in the betterment of the program. Then you have to do the diagnosis by sputum smear microscopy. Now in 1994 they said कि भाई you have to get a sputum done in order to diagnose a case of TB. However, it was faced with a lot of problem because of compliance from the patient, stigma of the patient, stigma of the lab technicians and all those things, and finally that hurdle was crossed. But in good old days of those, it was said that if you have to diagnose a case of tuberculosis, you can only do it via sputum. Otherwise, then slowly came up that no, you can diagnose it via the X-rays also. So again, not in 1994, few months or years later, those things also came into the picture. But when the program came in 1994, the DOT strategy clearly mentioned that you have to get a sputum done. During those days, it was 3 sputums, out of which 2 has to be positive. So you have to get that done in order to confirm a case of tuberculosis. Then you have to give the DOT, directly observed treatment, and there should be adequate supply of short course chemotherapy drugs. If the supply chain is not maintained, if the supply of the medicine is not there, how are the doctors or the health workers going to give the treatment to the people who actually need it? So we needed to strengthen the medicine supply. That's why the government has to be taken into loop. The government has to be held determined to fight with the disease. Because if the government is not on your side, you may turn into something like us. Now, sorry for the political comment. Anyways, in 2006, again, all the world leaders sat together 12 years from the start of the program, and they all sat and decided, what next? It has been 12 years, we have been running this program. The idea was to halt the particular disease, halt the spread of the particular disease. Now what to do? Once all the data from all the countries came out, it was decided, it was understood rather, fine, we had been able to arrest or halt the progress of the disease. The disease was going at a speed of Rajdhani. Now we had stopped it and we have kept it stagnant. The progress was stopped. It was halted. It may not be totally halted. The rate was not very high. It was quite under control, let's say, but the disease was still prevalent. It was not eliminated. Basically, what happened is the number of people who were infected by that particular disease in every year was nearly little bit more than the people who were actually getting the treatment and getting cured. So in 2006, all the big leaders sat together and they decided, okay, since we have halted this particular disease, halted the growth of this particular disease, now what we have to do is called stop TB. That means stopping the spread of this particular disease. Now, stopping is not an easy job. Stopping coronavirus throughout the world is not an easy job. Stopping tuberculosis in those days was not an easy job. But the government took this decision, okay, we will start this. So what the government said? The government said we have to pursue the DOT expansion and enhancement. The DOT clinics has to be expanded and it has to be modernized. It has to be enhanced. We have to address the TB, HIV patients and the multi-drug resistant patients, because 12 years from treatment there came the cases of drug resistancy or people or tuberculosis. HIV also came into the account in the year 2000. So TB and HIV work close hand in hand. So TB patients, HIV patients having TB and the multi-drug resistant patients were also have to be addressed. Their problem was much more severe than the actual TB patients. You have to strengthen the health system. If the health system was not strengthened, you cannot increase your outlook. You cannot increase giving better treatment to the patients. You have to engage all the healthcare providers. Now, healthcare providers have to be engaged. Why? Because it is not possible for me alone to take care of all the patients. I need my support staff. I need my colleagues. I need the local people of that area to help me to keep that disease controlled in that particular patients. So all the ancillary healthcare providers, be it ASHA, be it social health worker, be it the pharmacist, be it me, be it my seniors, be it my subordinates, or be it my colleagues, everybody has to be engaged in treatment of this particular disease. We have to empower the patients and the community. The community and the patients are needed to be made aware that what is this, how does it spread, and how can you actually stop it? Because if the awareness is not there, I cannot expect a good outcome for the society and the patient too. The stakeholders, the local political leaders, the gram panchayats, the MLAs, the MPs, they all have to be made accountable, not made accountable, but they have been asked to take proactive action in order to diagnose or find a particular patient, make sure he gets the treatment, make sure the area, the locality, the patient knows how this disease spreads, how can we stop it, what can they do as a patient, what can they do as a future patient, how to protect themselves. All these things had to be done. Then we have to do the research. If the research is not made, it is tough for this disease to get controlled, because drug resistance was on an increase, was rampant. TB and HIV, pediatric neonatal childhood TB, all this, they also played a very big role in spreading this particular disease. We needed newer drugs because the older drugs might get resistant after a certain point of time. So the second line of drugs was taken into account during those days. But again, given the resistance that we are having with the second line drugs also, we need much more newer drugs these days in order to control tuberculosis. So in 2015, again, all the global health leaders sat down after 14 years. First was after 12 years, this was after 14 years. Not 14 rather, I'd say, sorry, 9 years. My mistake, sorry, 9 years. They had sat down after 9 years and they said, okay, we have the data, and the data shows that we had been able to reduce the number of cases of TB that we earlier had. Initially we had been able to halt the progress of the disease. Now we had been able to reduce or reverse the trend of the disease. The number of patients was reducing day by day, but it was still on a huge number. The numbers were percentage wise or momentary wise down, but in actual the number was still huge. So then all the leaders sat down and decided, what can we do? Now in 2015, let me tell you, another thing happened. It's called the Sustainable Development Program, the SDGs. The SDGs came into account, and SDGs also clearly pointed out we had to stop TB from spreading, otherwise it will be a big burden on the health infrastructure. So in 2015, the End TB strategy was developed by the WN under the SDG program, and there was a paradigm shift from the past global TB strategies to now. What was the shift? This is the biggest question. See, the thing is that the government said SDG is saying you that you have to stop TB by 2030. That's what SDG said. Now tuberculosis people said fine. Now what is your definition of stopping the disease? So SDG said we want the disease to be stopped by at least 90% of what it is today. Tuberculosis people said fine, we accept your challenge. You finish it up to 90% by 2030. We'll finish up to 95% in 2035. So it was a win-win situation for both the parties. Now, how can you actually monitor the development, the progress of that program? See, we have got indicators. What are these indicators? If you can see on the slide, that on the left hand side, the reduction in number of TB deaths. The number of TB deaths that we have in 2015, we have to compare it with the data of 2025 and 2020, 25, 30 and 35. 20 and 25 are the years that we are going to track. Okay, how are we going? How have we went in the last 5 years? Because I cannot stop for 15 years or sit for 15 years or 20 years and then say, chalo dekhte hai kaisa haal hai. No, this is not like a relatives. So we have to make sure we sit down after every 5 years and check how was the progress. So in 2020, 2025, 2030 and 2035, these are the 4 times they are going to sit down and they are going to check how is the progress. The milestone is that there should be reduction in the number of TB deaths compared to the 2015 data. So in 2020 it has to be reduced by 35%, 2025 75%, 2030 90%, and 2035 is 95%. 95% of the patients who had died of TB in 2015 the number has to be reduced by at least 95%. Now reduction in number of TB incidences rate compared to 2015. That means how many number of people had TB in 2015. We have to take the picture of 2020 where it should be reduced by 25% or less than 85 per 1 lakh. In 2025, 50% reduction has to be there. That means less than 55 patients per 1 lakh. In 2030, it should be reduced by 80%. That means it should be less than 20 per 1 lakh population. In 2035, we have to reduce the incidence by 90%. That means less than 10 people per 1 lakh population has to be achieved in order for these goals to get completed. And most important thing, the main biggest stigma in our society, TB affected families facing catastrophic cost due to TB. The TB treatment should not be a burden on the family. It should be supportive of the family. That's why the cost should be 0%. Because why 0% is there? Because right now the government is giving TB medicines free of cost. If you go to any government center, you will get the medicines free of cost. The government is not charging any money from you. The WHO, the UN, the SDG group and the World TB group, they all are of the same idea that the treatment should not be costly. Like in our country, we are giving it free, but other countries, may not be free that much, but the society has accepted in that particular country, so there should not be any kind of increase over there. So TB is, as far as I remember, it is free in majority of the countries, and there should not be any amount of charge that should be collected from them. That's what the idea said. Now if I look at the data wise, this is the present scenario. Every year there is reduction in 1.5% of the cases. That is constant. What I am saying is that in 2025, that means another 4 years from now, I have to get it reduced. I have to get it reduced by at least 10%. 10% was of what was in 2015. Now this is my marker, this one over here. If you can see this line, if I have achieved this particular area, if I have reached over here by 2025, it is projected that this will be my graph, this will be the trend. However, that means it should be less than 5% per year. My target is that I have to end TB. So this is again my target, and I have to reduce it by 17% per year, and I have to reduce the cases up to less than 10 per lakh population in 2035. This is what the idea is. Now, how much we can go forward is something again subjective to area, subjective to country, subjective to continent. We don't have much of a TB patient in Europe, but TB patients are abundant in Africa and Asia. So continent wise it is different. Again in continent, country wise also it is different. So we have to take many things into account, and these are some of the targets that we have. Now how will this reduction over here, how is this going to happen? We have to optimize the use of current and new tools emerging from the pipeline of research, and pursue universal health coverage and social protection. And we have to introduce newer vaccines and treatment regimen for treatment of active TB diagnosis and latent TB infection and point of care test. Now, this end TB program stands on 3 pillars. What are these pillars? Pillars are, first is integrated patient-centered TB care and prevention. Pillar 2 is bold policy and supportive system. Pillar 3 is intensified research and innovation. So one says ki bhai, I want the patient to come at a particular place and get all the treatment from there. He doesn't have to run from here to there to there to there to there. The treatment is in one hospital, the tests are being done in one hospital, the counseling is being done in one hospital, and again the patient has to come for follow-up into another hospital. There is no point in doing such things. So we are saying ki you have a one place of contact or integrated patient-centered care. You come over here, your test will be also done here, your counseling will also be done here, your treatment will also be done here, your follow-ups will also be done here, your radiologicals, sputum voice test, everything will be done at one place. Integration has to be there. We need bolder policies, that is the pillar 2. If the policies are not bold by the government, it will be tough for them to control. So bold policies and supportive system has to be done. And pillar 3, and the most important part, is intensified research and innovation. If we don't do research, if we don't get newer treatment, newer techniques and newer tests to confirm the asymptomatic one, most importantly, it will be tough to control TB by 2030. So this research has to be done, and it has to be continued with full vigor to control this. However, these pillars stands on 4 principles. There are 4 basic principles. What are those? The government stewardship and accountability and monitoring and evaluation. The government has to come out and take a stand and work as a leader. The government is responsible for the TB spread in that particular country. The government has to monitor the TB progress in that country, and they have to evaluate the situation and work accordingly. If the accountability of the government is not there, it will be tough to control. Then building a strong coalition with the civil society and communities. If there is no coalition between you and me, there won't be growth of mutual, or your growth and my growth. There won't be any kind of peace. We'll always be at loggerhead. We'll be always at war, like something happens in many of the colleges that you might know. We have to have a coalition between us in order for both the parties to sustain and both the parties to work efficiently towards a betterment of individuals. Similarly, the government has to work in coalition with all the local areas, the local people, the local parties, the local policy makers, and they have to educate the people. They have to educate, they have to do a lot of promotion, marketing, activities, Otherwise, the message won't be reached to the people. Third is that we have to protect and promote the gender rights, ethics, and equity. Poor people suffering from TB, the owner of the construction area or the labor head says, okay, you're having TB, you will spread it to others, so you cannot come from tomorrow. That is a problem. If he loses his bread or her bread, it is a problem for them. So the government has to protect these people, protect their rights and the ethics and equity, and they have to support them for 2 or 3 weeks, first 3 weeks or 4 weeks, so in which the patient will be getting the treatment, the time which he has to stay at home. If the government does not support them, they will go out and venture in order to earn food for their family. And fourth is adaptation of the strategy and targets at country level with global collaboration. We have to adapt strategies and targets at our country level, but we have to work with the government all over the world. That's why the term comes, think globally, act locally. We have to see what the World Health Organization says, but we have to act according to the situation at our place. It might not be same as that of happening in the world, but we have to make sure that we follow their guidelines, we do changes accordingly in the way we need in our particular country. So we have to adapt the strategies and set the target at the country level depending on our need, not on what somebody else says. Now this is a particular poster of World TB Day that was being held on March 24th. It says you have to find, treat and cure the TB patients. You have to track their progress. You have to develop and implement newer tools. You have to mobilize the support. You have to test and treat the latent TB infection, the asymptomatic ones. You have to fight TB locally and globally, and most important in today's day, you have to share our stories. If you are not sharing the success of the stories of tuberculosis survivors, the tuberculosis programs, the people are not going to get aware. The people are not going to accept because they don't know. They need awareness. They need promotion. If you promote the particular thing, people will buy it. That's what happens. So this is something the government has to do. Now, as we talked about 3 pillars, this pillar also have got sub-support system. What are these? The pillar 1 says that we need integrated patient-centered TB care and prevention. So what do we have to do? We need early diagnosis of TB and screening of contact and high-risk groups. This one. We need treatment of the drug DSTs and the DRTs and the support, patient support. We need to manage the comorbidities like the COPDs, the AIDS, HIV and AIDS. And we have to prevent the treatment of persons at high risk and vaccination against the TB. I hope you remember the vaccination for TB, that is BCG. So you need to prevent the treatment of person at risk and you have to vaccinate them against TB, that is BCG. Now comes the pillar 2. This pillar 2 means the bold policies and supportive system. Now we need strong political commitment. It doesn't matter who is the ruling party. All the parties, irrespective of who is in power and who is not, who is in the opposition, doesn't matter. Everybody has to be taken into account and everybody has to made a party into this thing. If there is no political commitment from them, it will be difficult to arrest the spread of this particular disease. You have to engage the healthcare providers, that is the private setups also, and universal health policies and regulation framework of case notification has to be done, and social protection needs to be done too. Comes to the third and most important, research. That's what we say. We have to research and promote the newer innovations, the CBNAs, the gene experts. People have to know about it. So we need much more newer medicines. We need much more newer techniques to diagnose. And discovery and development of newer tools, interventions and strategies has to be done. See, the target is this. We need to have less than 10 patients per 1 lakh population by 2030. And given this particular current annual decline is 1.15%, we need to accelerate this growth, this decline to 10% at least per year. So we have come out with an idea, 90. That means we have to reach at least 90% of the people having TB, and this 90% has to be of the key population, and there has to be 90% treatment success rate. If all these things are achieved, it will be easy for us to control this particular disease. This is something I'm not giving to you as of now. I'll stick with this one. The key population group. Who are the key population whom we need to take care of? People who have increased exposure to TB due to where they work or live. That is the prisoners, sex workers, minor, hospital visitor, healthcare workers and community health workers. Who are these people? People living in urban slums, people in poorly ventilated or dusty conditions, who are in contact with TB patients including children, work in environments that are overcrowded, work in hospitals or are healthcare professionals. They are the people who have increased exposure to TB. Now next part is the people who have limited access to quality TV services. These are the most prone people. That is the migrant worker, women in settings with gender disparity, children, refugees or internally displaced people, illegal minors and undocumented migrants. Who are these people? They are people from tribal population, the homeless people, people living in areas hard to reach, the remote areas, people in homes for elderly, the old age homes, people having mental or physical disability, people facing legal barriers to access care, and people who are lesbian, gay, bisexual or transgender. Then the third section is that the people who are at increased risk of TB because of biological or behavioral factor that compromises the immune function. That means people who live with TB, people having diabetes or silicosis, people who undergo immunosuppressive therapies like in cancer, the people who use tobacco, people who suffer from alcohol use disorder, and people who take IV drugs or the IV drug abuser. These are all people who are more prone to having TB, and we have to protect all these groups. So this was a bit brief about End TB program. Next we have the tuberculosis, fifth, and that will be the last of tuberculosis, where we'll talk about all the algorithms and all the major parts that we have left in tuberculosis. It will be a bit long class, so I hope you all are doing well in your assignments. In case you have any problem or you want a model answer, feel free to write to the department. We will try to do whatever we can, but be interactive. Let us know where we are going wrong or where you want us to improve. Any suggestion from your end is always welcome. So till then, take care, have fun.